So briefly, can you tell me what a brain aneurysm is and how they originate,
Yeah, so it's a question that we get asked quite a bit, actually, both with ruptured and unruptured aneurysms. And the way I describe it is, if you think of our vessels, our blood vessels, as just pipes, they're just tubes that carry blood to the brain. What happens in patients who have brain aneurysms is that part of the wall of our blood vessels gets weak for a number of different reasons, and it starts to balloon out. And like any other balloon, if it gets too big, it can pop or rupture. And unfortunately, that's the event that we obviously want to prevent, because that could be a catastrophic event. What causes them? The honest truth is, I don't think anybody really knows. There's multiple risk factors. The most commonly identified risk factors are cigarette smoking, uncontrolled high blood pressure, and then family history, which of course you can't control. But having multiple first-degree family members with brain aneurysms, so mom, dad, sister, brother, kids, that is a clear risk factor for somebody who probably should be screened by their PCP or neurologist.
Great, thank you. From an endovascular standpoint, what indicators guide your decision-making for intervention following a rupture?
Yeah, so in terms of, so patient comes in with a ruptured brain aneurysm. The first priority is you want to treat that. You want to secure the brain aneurysm, because we know that the risk of re-rupture in that first 24-hour period can be up to 10 to 15%. And mortality or death associated with that re-rupture is 50%. So it's a coin flip whether people are going to live or die if that brain aneurysm rebleeds. So when we talk about treatment options, there are both surgical and endovascular options. And I would say that the majority of what we treat can be addressed from an endovascular standpoint. So that usually is our first approach. There are some exceptions to that, but typically that's what we reach for.
Great. So thank you, Michelle. I know that you just finished up a case in the OR and you're working on helping patients through recovery. So thank you so much for taking the time.
Thank you guys for being here where I am.
Dr. Smith, we're just focusing on the basics, what a brain aneurysm is, risk factors, but let's talk about pre-hospital setting. What are some of the complaints that EMS may hear that could trigger that this could be ruptured brain aneurysm?
Yeah, no, that's a great question. Can everybody hear me okay? That's a really great question as far as what is it like, what does it look like before someone even gets to the hospital for a ruptured brain aneurysm patient. Because there's really no early warning signs when a brain aneurysm ruptures. It's often a youngish, healthy person. Doesn't have to be, but often a young, healthy person with no real medical history. And if they're still conscious, they're complaining universally of the worst headache of my life. People universally know, holy cow, this is different than my normal headache or migraine, something's really wrong, and complaining of that headache. And then depending, occasionally there can be a sentinel headache, a smaller one that's still a pretty big one. We have to be thinking about that, in the medical field or pre-hospital. But if it really ruptures, it's a profound thing. And the interesting, sometimes tragic thing in pre-hospital setting is a young, healthy person, someone can assume that they're having a headache for other reasons. Or maybe we were out partying all night last night and we're hungover, right? And young, healthy person. So when EMS shows up, it's really important that we have ruptured brain aneurysms in mind, and we do the right thing for that patient and take them to the right hospitals, which includes making sure, obviously, they're stabilized, their ABCs, their blood pressure's under good control. Only certain hospitals are equipped to take care of ruptured brain aneurysm patients. Of course, we want that patient to go to the closest ER, but if there's options, we want them to go to a center that is capable, like Bryn Mawr or Paoli, that's capable of taking care of those patients.
Great, thank you. Dr. Ramchan, so when EMS and pre-hospital medicine may appreciate the signs and symptoms or thinking ruptured brain aneurysm, how helpful is that to really get them to definitive care in an emergency setting?
How helpful is that assessment of it being a rupture? Yeah, I mean, like Dr. Smith was saying, we have this adage, I think, in neurovascular neurology, neurosurgery, which is that time is brain. And we know that the sooner we can get patients to the care that they need and provide the care that we can provide, the better their outcomes are. So high clinical suspicion for a ruptured brain aneurysm, obviously identifying that as soon as possible, having that on your differential and bringing them to a place where, like you were saying, where we have the capability to treat them, it can make a huge difference in their overall course.
That's great. Thank you. So Dr. Smith, what do we think about with blood pressures for pre-hospital treatment? What do you normally see as far as blood pressures? How high do they go, and what effects can that have? And where would you like to see the blood pressures when we have the medication that we can stabilize these patients with?
Yeah, so for ruptured brain aneurysm patients, almost universally, their blood pressure is going to be extremely high. It doesn't mean they had hypertension at baseline. It's an adaptive response. So when a brain aneurysm ruptures, the pressure inside of our head skyrockets really quickly. That's what gives someone the really bad headache. And to compensate for the increase in intracranial pressure, to continue perfusing your brain, your body auto-regulates, so then your blood pressure goes up to match it. That's somewhat of its protective response, but it's also maladaptive, because once a brain aneurysm ruptures, our body can tamponade it and stop that bleeding. That's what will allow someone to stay alive long enough. They'll get to the hospital, have us treat them. So, but if the blood pressure is really high, it'll promote more bleeding. So when you come on site and see a patient and they're having worst headache of life, plus minus neurodeficits that you're thinking about stroke, possibly ruptured brain aneurysm, you're going to want to have that blood pressure in a normal, not so high range. Also not too low, because then we won't perfuse our brain enough. And that could get confusing, but the thing is really that headache. If someone's having stroke signs or symptoms, like hemiplegia, can't get words out, temporary vision loss, and no headache, then you're thinking about an ischemic stroke where there's a clog in a vessel and your brain's not getting enough blood flow. In that situation, we often want the blood pressure higher. But if someone's having stroke signs and symptoms and that really bad headache, we have to assume it's a ruptured brain aneurysm, and you don't want the blood pressure that high.
Good, thank you.
And so in general, 100 to 150 is a good range.
Thank you. For those of you who aren't local, and this really is happening all across the nation, we have more closures of health systems and hospitals in the area, which makes it extremely difficult for the pre-hospital and EMS services, because now they're inundated with just too many emergencies to handle at once, let alone compounded with longer drive times. So I just want to stress, when we have a patient who's going to be at another hospital, they've got possible head bleed, we then have to work with interfacility transportation. And so I think that's kind of the drive home point of some of this, is that if we can reach a lot of our different partners, community members, physicians at primary care offices, to educate them on the signs and symptoms of aneurysms, we can hopefully direct them to a hospital that's capable of doing these endovascular procedures. And some of that's going to be the workup initially and having the services on 24 hours a day, such as Brynmar. So what are some of the things, Dr. Smith, that you may have ordered when a patient arrives, EMS is saying, I think this is a subarachnoid hemorrhage or brain aneurysm rupture? What are some typical things that we look for, and what images would you order?
Yeah, so when we hear that, we know that that patient is going to be a very sick patient. So first thing is ABCs, make sure they're stabilized, and then Ds for neurologic disability. So ABCs, we have our bases covered. We think about blood pressure control. Those patients usually get a gram of Keppra, so a seizure prophylaxis medicine up front. And then if they're stable enough, they'll get a non-contrast head CT to prove that they have brain bleeding. And again, if they're stable enough and they have a large bore IV, they'll get a CTA up front. So sometimes that used to be controversial in the past of, hey, we don't want to expose a patient to an unnecessary dye load. They're probably going to get an angiogram anyway. Well, we will tell you that the information we get from the CTA of the head and neck is invaluable in us planning, identifying that it truly is a ruptured brain aneurysm, saving time for when that patient does pretty quickly get on the angiogram table, because we already have our equipment out, we know what we're doing or how to treat that aneurysm. So that's the usual imaging workup after they've been stabilized.
Thank you. And Dr. Ramchan, what is the most helpful information that you want to receive, whether it's from pre-hospital EMS or the emergency department physician, that's going to help guide whether or not you're able to do an intervention or that could help drive that care?
I think, for me, obviously the symptoms of the patient presented with are critically important. But also the state of the patient, I think, is really important when EMS gets there. We have different clinical grading scores that we use to help us prognosticate and predict how the patient's going to do. And a lot of that's actually based on that initial clinical assessment. So the Hunt and Hess scale is one of these things, and that's based on how does that patient look when you get there. So somebody who is awake and alert with a headache and can tell you I'm having the worst headache of my life is a very different patient who will likely have a very different clinical course than somebody who is comatose, obtunded, sometimes with evidence of multi-system organ failure. These are patients who, like Dr. Smith said, are very, very sick. When a brain aneurysm ruptures, there is a massive stress response in the body, and those stress hormones can cause heart failure, which can then cause kidney failure, liver failure. These are very, very sick patients. So that kind of patient is very different than the first one I described. So understanding what you're dealing with can just help us in terms of knowing what to predict over the 3-4 weeks that they're in the hospital.
Thank you very much. And Dr. Smith, from a neurosurgical standpoint, so we've got the skull, which is a closed cavity, and now we've got an introduction of a lot of blood that's going in there. So what's happening inside the skull when you've got this excessive bleeding happening? And then if you get a call, what can you do to stabilize the patient at the bedside?
Yeah, so you bring up a really good point. It's called the, correct me if I'm wrong, Monroe-Kelly principle, where our skull is a closed box made of something stronger than cement. That skull is not budging. And there is spinal fluid inside our skull, there's brain matter inside our skull, and there's blood inside our skull. So if you add anything else in there, there's just no room for it. And what that means is the pressure is going to go up, and something else has to get compressed. Unfortunately, what gets compressed first are the blood vessels, so you're reducing your perfusion to your brain. That's injuring your brain further. The next thing that gets compressed is your brain tissue itself and the cranial nerves. So if that goes on too long, inevitably someone unfortunately dies from that. So number one, we have to stop the bleeding. Our body, interestingly, is usually what stops the bleeding on its own, forms a thrombus there, the brain pressure tamponades that bleeding, and with the thrombus that your body and your bloodstream is designed to form, if you're lucky, the bleeding will stop. But we know that aneurysm will rebleed almost inevitably within the first 24, 48 hours. So we have to cure that aneurysm so it doesn't rebleed. We also have to deal with the brain pressure did build up. So what else can we do to alleviate some of the matter or the fluid that's in there? Our ventricles, the fluid-filled spaces in the center of our brain, have spinal fluid inside of it. So we can actually, at the bedside, do a small burr hole. It's not an OR procedure. It can be done in the OR, but it doesn't have to be. Just at the bedside, shave a little bit of hair, a small burr hole here, which is a twist drill, a hand drill, and put a tiny little silicone tube called a ventriculostomy deep inside the center of those ventricles. That does two things. It can, it'll measure the intracranial pressure, so you have a gauge about how high or low the pressure is. It's also therapeutic. It'll drain off spinal fluid, and our body can afford to lose actually a lot of spinal fluid at any given time. Our body makes about a Coke bottle full and absorbs it a day. So when we put that in there and draining fluid, that brings the pressure back down to normal. In the meantime, there's other medical things maybe you want to talk about that can be done to help with that pressure too.
Yeah, so medically, we can give medications to decrease swelling. There's 2 different medications that are available in the ICU. One is basically a concentrated salt water. It's called hypertonic saline. And that just brings the water out of the brain into the veins and the arteries. And so you eliminate that pressure, that aspect of the pressure from the brain. And the other one is a drug called mannitol that has a similar effect. But both of those things can certainly help to decrease the pressure. We can do other things like hyperventilate the patient. This affects our I won't get into the science of it too much, but it affects how much CO2 and oxygen are in our blood vessels, and that can also help to decrease the pressure in the brain. So those are all medical measures that we can do at the bedside. But ultimately, often the definitive treatment is something like ventriculostomy to open up the cavity and to give us a little bit more space.
Great, thank you. And then for our EMS partners, when would you think about airway management in the pre-hospital setting? Because I know a lot of these patients may have reduced mentation, they could be lethargic. Is it going to drop off quick, or when do they really intervene to control that airway?
Yeah, I mean, again, I think that goes back to the point about ABCs. When you guys get there, how does a patient look? We often in the ICU setting use the Glasgow Coma Scale, and we usually say anything less than an 8 warrants intubation. So that's usually the metric that we use in the critical care setting. I'm sure it's something similar for you guys as well. If the patient looks that bad when you get there, they're probably not going to get better immediately until they come to the hospital. So definitely would benefit from a controlled, if possible, elective intubation in the field as opposed to having to scramble and do it, in the ER when they're really crashing.
Great, thank you. Dr. Smith, what about ages? What age groups are affected by this? Is there a trend, or what would you think about that?
Yeah, so the statistics tell us that for ruptured aneurysms, I believe it's a little bit higher proportion of women compared to men. And often it's women in middle ages, but also our elderly population, especially our healthy elderly population around this area, does have a relatively... Ruptured aneurysms don't have a high incidence in the population, but we see it all the time for us. So our older patients also can have ruptured aneurysms as well. And just taking one step back, as far as pre-hospital measures for raised intracranial pressure, something that's very simple that can be done pre-hospital in the ICU, not during our procedure, is elevating the head of the bed. So that actually can raise your intracranial pressure as well, as opposed to having someone completely flat, supine, or in Trendelenburg. So just keep that in mind as well. And then another thing, just that, we talk about people coming in very severe, near comatose, an acute event like that, needing to do pretty drastic measures to alleviate their brain pressure. What's amazing for us is if people do well enough or hang on in the initial phases, once we alleviate that pressure and of course get the aneurysm secured, these patients often are awake the next day and talking to you. They don't remember anything about, the bad part that happened, but once we get that ventriculostomy in and the brain pressure normalizes, as long as there was not extensive initial brain damage, it's really remarkable that they're kind of wide awake and talking to you and normal the next day. You have to get them through the rest of the hospital stay, make sure their aneurysm is safe and all the other things that could happen, but these patients can have really good outcomes. So much of it depends on what happens, pre-hospital in the initial phase, hyperacute phase.
Great, thank you. So we'll just do a quick case study here. Dr. Ramchan, I'll ask you just about what assessment you would do for this patient once I explain it. And then Dr. Smith, maybe if you could just walk us through who you would take to the OR, who you would take to the Neuro Lab, and what you might do and why. So this would be a 58-year-old woman, sudden headache, vomiting, photophobia, so sensitivity to light. The GCS is 13, so they're not completely mentating, they're not clear, they're a little bit confused. Blood pressure's elevated, 190 over 100. EMS appreciates a possible subarachnoid hemorrhage and initiates transfer immediately. So they arrive to the ED, you come to the bedside. What does your assessment look like for this patient?
Yeah, so the first part of my assessment, again, being neurofocused, I want to look at their vitals and their basic, again, ABCs. But then after that, I want to focus on their neuro exam. So subarachnoid patients, we pay a lot of attention to how awake somebody is. They tend to present a little bit less commonly, I think, with the focal neurological symptoms of weakness, numbness that we see with an ischemic stroke, but often they come in with varying levels of arousal. So that to me is really important. And then of course the rest of the neuro exam. And then the things that I want stat, I guess, in the emergency room for workup, so the non-con CT, the CTA labs, so basic labs, including the coags, so PT, INR, PTT. And what's really helpful from an EMS standpoint is, do we know if they're on blood thinners? Often they get reversed if they are. So if that history is established, that's very useful. We can give them products emergently to reverse some of those things. Yeah, that's basically it. The exam, the labs, and the imaging. I think those are three most important things.
Yeah, and the medication.
And the
Yeah,
medications,
yeah, thank you. So now we've confirmed using CT and CTA that there's most likely a ruptured aneurysm, 38-year-old female. What procedure, if any, would they get after that, and how do you determine?
Yeah, that's a great question. So after they've been stabilized, the next thing I'm thinking about is, do they need a ventriculostomy or not? There's kind of a spectrum of me and my partners of what the threshold is to put in a ventriculostomy. It's a very straightforward procedure, benign, low risk, but any procedure has risk. So if someone is meditating okay and they're not on a trajectory where this is where that information of how were they looking in the field, were they wide awake and perky and talking and now they're kind of sleepy, that's a trajectory where I'm going to put in a ventric because I know where that's headed. If they've been kind of a little bit stunned in the field, they're similar. For me, before we start any intervention, and depending on what the scan looks like, I likely am going to hold off on putting in that ventric because often we don't need it, and we'll be monitoring their vitals while they're under anesthesia. But again, if there's a doubt, it's usually safer to put that in so you can also directly monitor their ICP. So depending on most, I would say, probably nationwide, but certainly in our practice, I would say 90% of ruptured aneurysms these days get treated endovascularly. So and we could talk about the open stuff in a minute, but that starts with someone going on the cath lab table to get a diagnostic cerebral angiogram. There's a lot of fancy equipment where we'll get most perfect pictures. Well, take a step back. To do a DSA, or diagnostic cerebral angiogram, we have to put a form of a specialized IV called a sheath in an access artery. So that's often the femoral artery, but sometimes more and more it's the radial artery, just like cardiac interventionalists do. And then through that, it's long, tiny, thin tubes, but long, that go through there. They get parked at the blood vessels at the base of the neck, the carotid arteries, vertebral arteries. And because the other end's outside of our body, we're able to inject through that a form of a contrast dye, and our bloodstream carries that dye up to the brain, the vessels in the neck and the brain, and the angiogram machinery takes those really fast pictures, including 3D rotational angiogram pictures where there's a software workstation, and we can literally, it's like a video game, rotate around in 3D the entire vessel tree, the aneurysm, and understand every aspect of it. That whole process, it sounds involved, and it is, but our team does this day in, day out. That whole process of getting those fancy pictures usually takes about 20 minutes. Based on that, and based on the CTA, actually, we have a good sense of if it's favorable for endovascular treatment as opposed to open surgery and clipping and other things. So I would say 90+% of patients are okay. They're on the cath table already. If those pictures look good and we have our implants ready, we'll get started with the interventional part of the procedure. Usually all of this is done under general anesthesia. For interventional part of the procedure, a most basic form of treatment is called coil embolization. We don't mind that this is what I tell my elective outpatients. I don't mind that the aneurysm is there. Your body doesn't mind that it's there. It minds if it's ruptured or bleeding. So as long as we stop the blood from getting in the aneurysm, that's the goal. So using teeny tiny little microcatheters and our screens under X-ray guidance, we can navigate a microcatheter gently, carefully into the opening of that bubble, that balloon that bursts. And again, because the other end of the microcatheter is outside your body, we push through it these teeny tiny little platinum coils. They really, if you were to have a little tiny curly hair in your hand, that's what they're like. They're really tiny, gentle, soft. But we're able to thread these tiny coils to pack that aneurysm filled with coils, platinum material. And once it's completely packed with coils, the blood can't possibly get in there anymore, and it protects it immediately from re-rupturing. Over time, your body actually does the rest of the work. Once there's no more blood flowing into the aneurysm, your body sends signals to grow a new layer of blood vessel skin cells across the opening of the aneurysm to completely seal it off. But that takes time. So number one, up front, we want to fill that with coils to protect it from re-rupturing. And then sometimes we need adjuncts. If that balloon or that bubble has a wide neck, a wide opening to it, the coils might not stay there. So we use forms of stents within the parent or the main pipe or main vessel to kind of buttress and support those coils to stay there. That's called stent-assisted coiling. And there's a couple other variations on that theme in the modern era. Again, the technology to do this has advanced at an exponential pace over the last 5, 10, 15 years. So intrasaccular flow diversion, all these things, which put me out of business from the open surgery standpoint. I'm happy about that. Occasionally someone, if their aneurysm ruptured and they actually have a big mass focal clot of blood in the brain that's putting too much pressure on like your frontal lobe or your temporal lobe, we can't get that out through the catheter. So that's still the rare occasion where I have to take someone to the operating room, temporarily take off their skull bone, evacuate the blood that's there, and then we can clip the aneurysm at the same time. But we're always hopeful that we don't need to do the open surgery for our patients.
Great, thank you. So a couple more questions here, and then we'll start wrapping it up. Dr. Ramchand, after a procedure like this, that Dr. Smith went through, what's the course like throughout the hospital stay? And what are things that you're looking for during that course?
Yeah, so one of the first things that I tell patients and their families is just settle in for the next 21 days. Our typical timeline for these patients, almost irrespective of how they look when they came in, is to monitor them in the ICU, ideally in a neuro ICU type setting, for 21 days. And the reason for that is that, like I said, these patients, they're not just brain sick, they're really whole body sick. And there are multiple complications that can arise in the ICU setting going out to that 2 to 3 week timeline. So patients can develop what are called cardiomyopathies, where they actually develop heart failure as a result of the bleed in the head. Patients can develop lung injuries that require them to have a breathing tube and additional procedures to try to get that breathing tube out. They can get kidney injury, liver injury, and then there are also other neurological issues that can come up for these patients. So seizures can be something that these patients end up getting in that time frame. There is a very specific syndrome called delayed cerebral ischemia that we know affects a lot of these folks. It's actually, I think, the #1 contributor to mortality once they survive that initial bleed. And this is a phenomenon where, for a multitude of reasons, the blood vessels in the brain can narrow after a bleed. And it actually impairs blood flow to normal tissue. So they can actually have an ischemic stroke where there's lack of blood flow in addition to a hemorrhagic stroke with the initial subarachnoid hemorrhage. And managing these patients is a little bit of a tightrope. Sometimes there's medical things that we can do. Sometimes they come back to the procedural suite where we have to inject medications through those catheters into the brain to help alleviate some of that. So these are the kinds of things that we're monitoring for in that 3-week time course. And there's all kinds of studies that we do in addition to lab work. We get these things called transcranial Dopplers, or little ultrasounds of the head, and that tells us whether that phenomenon of DCI or delayed cerebral ischemia is impending, and then we can treat accordingly. But yeah, these are very, very sick patients. I will say, I think 10, 15 years ago, and you may remember this as well, I remember subarachnoid hemorrhages coming in almost universally on fire. Like, I just felt like they were always crashing and burning. And now I think largely, again, because of pre-hospital care and that emergent, ED recognition, a lot of the things that we do to control their blood pressure, the ICP, emergently, these patients some of them can be very, very sick, but it's not quite as bad as I think it used to be a couple decades ago.
Yeah, I agree. And also the ICU care too, and then our ICU specialty and nurses. And here we have critical care as well, which is really awesome because early warning signs of vasospasm or delayed cerebral ischemia get picked up, so we're able to, head it off before it becomes irreversible brain injury. So I rarely see that for patients. And in training, we would have young, healthy patients come in, they were saved, right? And then, unfortunately, they would have major strokes. It was not uncommon for them during their hospital stay to have major strokes. I think, recognition of those signs and symptoms has gotten better. And then, quite frankly, the ICU care has gotten more sophisticated over time.
Great, thank you. And just one more question, and then I'll start to wrap things up here. What about unruptured brain aneurysms? So if they'll come in to see you as neurosurgeons, which ones are you going to treat? Which ones are you going to watch, and why?
You first.
Like I need an hour for that question. Oh boy. Well, I think ultimately it's an individual decision based on the patient sitting in front of me and the aneurysm characteristics. What's the size? What's the location? And then what are those patient risk factors that we talked about earlier? I think the higher the risk, obviously, of this aneurysm rupturing, the more you are inclined to offer treatment. I do think we have to be aware of the fact, and I always counsel patients on who are unruptured, who are coming in electively. Listen, the things that we do are low risk, but they are not no risk. There are complications that can happen as a result of treatment. And it's one thing when you're ruptured and we have to do it, we don't have a choice. But if you're unruptured, I think we have to be a little bit judicious about how we treat these aneurysms. And so those are the factors that I think about when I see these patients. But it really does vary from person to person.
Yeah, and I see a lot of I see a lot of outpatients who come to me because they have incidentally found brain aneurysms, so obviously unruptured. Sometimes it's because they have a strong family history and they got screened and they also have one. I would say universally that patient, the unruptured patient who comes to my outpatient clinic, is terrified. They feel like they're a ticking time bomb, and a lot of my job is reassuring them that if you need to be treated, we're going to get you through that, no problem. We have a little work to do, but we're going to get you through that and you're safe. And sometimes even harder are the low-risk aneurysms that really are unindicated to be treated. So helping counsel that patient to feel okay with that and how are we going to monitor that, and often lifelong. The great news is there are really good research studies, longitudinal research studies that have looked at unruptured aneurysms to help determine risk factors for rupture. That helps guide our decision. For example, size of an aneurysm is an important factor. I'm going to get a little technical on us. The ISUIA dataset, ISUA dataset, intracranial international study of unruptured intracranial aneurysms, so ISUA dataset, tells us that an aneurysm in the anterior circulation, so the carotids as opposed to the basilaries, less than 7 millimeters, has an extremely low risk, namely 0% 5-year risk of rupture. We know that there are some aneurysms smaller than 7 that do rupture, right? But on the whole, we know those are lower risk aneurysms. There's the phases score study, which refines that a little bit, that if you have an ACOM aneurysm, that is probably high risk, and even though less than 7 millimeters, should be considered for treatment. So there's a whole data set out there to help guide us. And on top of that, what I also tell my patients is, here's the bad side of the story, here's about brain aneurysms, and if they rupture, we have to talk about that. Here's the happy side of the story with brain aneurysms. They're actually extremely common in the general population. 1 in 50 people has a brain aneurysm. A lot of people don't realize that. And we know that 1 in 50 people is not having a rupture event. That'd be an epidemic, and it's just not happening. So, and they find the 1 in 50 number based on autopsy studies of people dying of natural causes, nothing related to brain stuff, and that's how they find it so common. So the reality is only an extremely small fraction of brain aneurysms actually rupture, and there's good data to help guide which are the low or no risk aneurysms. Those are the ones that we should keep we're not going to forget about them. We're going to keep a close eye on them. We're going to modify our other risk factors like hypertension. But if they're low or no risk, we shouldn't treat those prematurely. We're going to watch them. Usually it's an annual MRA. And if they change or grow at all, we don't wait for them to get to the 7 millimeter size. Then we're going to go ahead and treat. But we're going to keep a close eye on them. If it's anything higher than the low or no risk type, because the consequence of rupture, sometimes that data set tells us it's a 1.5% 5-year risk of rupture. That's still really low. But we know the consequence of if it ruptures is dire. So that's when we usually cross the threshold and start offering treatment.
Thank you.
Yeah.
I'd just like to take this opportunity to thank our EMS partners, pre-hospital staff members for the collaboration and being the front line and helping to get the patients to definitive treatment and stabilizing them pre-hospitally, because a lot of patients don't ultimately make it to the hospital. So, fantastic job. We love working with you. And we hope that we can continue to educate EMS and pre-hospital staff in and around the area so that they can identify brain aneurysm ruptures and get these patients to the right place the first time. And thank you to Dr. Ramchan and Dr. Smith for the work that you do as of 45 minutes ago.
Still on college.
And thank you to everybody all across the country who's come here to visit with us. We love to have you. And we're a little pressed for time. I do apologize for that, but I'll give my card out to anyone who may have questions. They can please email me. I'd love to talk more with you. So I think that's it for right now.